This is lecture 2 of a two-part series on mental illness. Many of us are very interested in the nervous system just because of this issue. This is one of the main reasons why people are drawn to neuroscience. When something goes wrong with the brain, we want to know what's going on inside. And of course, in humans, it's going to generally be characterized as behavioral deficits and changes, and we put those into the categories of mental illness. So this is, really the only topic that we cover thoroughly over 2 lectures. Vision, I think, is the only exception to that. And and even then, with 2 lectures, it's still not enough to cover all of these issues. If you are interested in learning more about mental illness, injuries to the brain, diseases of the nervous system, all of which we've only covered just a little bit, especially the latter 2, I encourage you to take the diseases of the nervous system course. It's an excellent program, an excellent lecture series, and I particularly would encourage you to learn more from those courses as well if you are interested in this topic and want to explore it more in depth. That being said, why don't we talk more about mental illness? This is a slide that we saw before about how we diagnose and classify mental illnesses. We have covered a good chunk of the 20 or so large categories that are characterized in the DSM-5. We have talked about feeding and eating disorders. We have talked about various neurocognitive disorders having to do with neurodegeneration. Parkinson's disease is an example. Depression, anxiety disorders. We talked about bipolar, schizophrenia, a bunch of these. But today we're going to cover a few more of these categories. We're going to talk about neurodevelopmental disorders, and we will also discuss personality disorders, will be the second thing that we'll go through. Last will be disruptive impulse control and conduct disorders. Now, one thing about these various categories is that there's overlap. This is one of the complexities of trying to diagnose mental illness. Certain features that occur and over the course of development, they might be characterized as neurodevelopmental disorders, but some of those behavioral disorders might include other symptoms from other categories, such as anxiety or depression, or disruptive impulse control and conduct disorders. They tend to go along with each other. Same for personality disorders. Schizophrenia gets its own major category, but it also appears within personality disorders as well. And it has certain aspects of disruptive impulse control and conduct disorders. So this is one of the challenges when dealing with mental illness, is that we can focus on particular behaviors, but those behaviors tend to be overlapping across multiple disorders, and you'll have to take a look at the entire gestalt, the entirety of the symptomology of a particular patient in order to best diagnose them and find them treatment. And also, it's important to be flexible when dealing with these categories as well, because the initial diagnosis might have overlooked certain symptoms, and you may need to change course of treatment because of new developments. Neurodevelopmental disorders include the following. So there are intellectual disabilities. This is formally called mental retardation. Common causes of this are fetal alcohol syndrome. Too much alcohol during development will lead to developmental issues in the brain, as well as other physical symptoms. Genetic and chromosomal conditions such as Down syndrome and Fragile X syndrome. This leads to intellectual disabilities, and even infections during pregnancy can lead to issues. I just saw a report from the National Institutes of Health saying that for the vast majority of cases of people infected with COVID-19 during pregnancy, there are absolutely no problems at all for the mother and including the offspring. And in fact, babies born from pregnancies with COVID-19, I saw a report earlier this week showing that the babies have antibodies, so they come out being immune to COVID-19. So autism spectrum disorder and ADHD, or attention deficit hyperactivity disorder, we're going to cover these in detail. I won't talk about them much more here. There are specific learning disorders such as dyslexia. This is a term that refers to difficulty with reading, and dysgraphia, which is a term to describe difficulties with putting one's thoughts onto paper. So these are very specific disorders. Motor disorders is another. Developmental coordination disorder. This is delays in sitting and walking. Children might find it difficult to jump or perform tasks such as tying shoelaces. And then stereotypic movement disorder, repetitive non-functional motor behaviors such as hand waving, head banging, and that differs from normal activities. And then tic disorders, so twitching of muscles of the face, and I believe Tourette's is put under this as well. So Tourette's is considered a tic, usually is associated with physical tics, and then spontaneous vocal output. Communication disorders also are considered to be neurodevelopmental. We've already talked a bit about this. We had an entire lecture on language. Language disorder is difficulty finding the right words and forming clear sentences when speaking. So this is usually associated with developmental issues, not specific to, say, like stroke or injury. And then childhood onset fluency disorder. This is known more commonly as stuttering. Autism spectrum disorder, or ASD, this is a developmental disorder that affects communication and behavior. Even though autism can be diagnosed at really any age, it's really said to be a developmental disorder because its symptoms generally appear within the first 2 years of life. So it's usually, in the first year you might be able to detect some behavioral deficits that will be characterized as autism, and we're getting better at diagnosing children with autism even within the first year of life, but usually between year 1 and 2, this is when it will become most obvious. Difficulty, so it's characterized with having certain symptoms. This is just a relatively short list. Difficulty with communication and interaction with other people is one of the features of autism spectrum disorder. Restricted interests and repetitive behaviors is another thing that characterizes autism. And symptoms that hurt the person's ability to function properly in school, work, and other areas of life. So with autism spectrum disorder, one thing that we can see as a particular behavioral deficit is that, and this is in contrast to neurotypical individuals, people with autism tend to focus on features of the face that are not critical for socio-emotional communication. And so we have talked about this, how the eye makes saccades, two features of the face. And that oftentimes so this is an eye tracing of different faces presented to a neurotypical individual or to individuals with autism. And you can see a neurotypical individual, they will typically focus on the eyes. They will then also go to the mouth, generally looking at features of the face and the eyes. So we are very communicative, especially about our emotional state with our face, as we talked about when we talked about the emotions lecture. And we have to, for us to read the emotions of other people, you have to look at people's faces. And so most of us will flip between the eyes. We'll look at other features of the face to read the person's facial features. People with autism tend to not do this. They tend to not focus on the eyes. They will generally focus at high contrast markings within the face, so sort of tracing the edges of faces, looking at the mouth. Very little focus on the eyes. So in fact, we can look at this in different categories here. So this is from a very old paper, and so the quality of the graph is not the greatest. But we can just, so the list of the feature of the different bars are right here. And this is then looking at the percentage of time spent on features of the face for neurotypical individuals. They will typically spend about 90% of their time focusing on features of the face. And nearly 80% of that is on the eyes. So the eyes are a major focus for neurotypical individuals. For so these first two categories are mutually exclusive categories. So 90% on features, 10% off features. For the on features, it's mostly on the eyes, and then on the nose, a little bit on the mouth, but really not too focused on the mouth. For people with autism, it's not like that they don't focus on any features of the face. About 50% of their time is spent on the face, maybe closer to 60%, but 40% is not. That's spent on features not related to the face. And when they are focusing on the face, they do have focus on the eyes, but it's only about 50%. So you can see the ratio is approximately the same, but the overall amount is a lot less. And so that's really a major deficit. They're mostly focusing on non-facial features. Or at least, I shouldn't say mostly, but a huge chunk of their time is focused on non-facial features. So. Some of the neuroimaging for autism spectrum disorder shows changes within how the brain functions when looking at faces. So faces elicit greater activity when using fMRI in the fusiform gyrus. This is indicated in the scan in the graph on top. So you can see that in control individuals, when shown the face over the next several seconds, that's what's being shown here. This is showing signal change. So this would be increased activity. Within the fusiform gyrus, when we're shown faces, this increases the most about 6 to 8 seconds post seeing a face. And so it's an increase in activity in this area. Individuals with autism spectrum disorder, you can see that they have a less of an increase in this area of the brain, which makes sense given that they seem to be attending to different features of the face and that they're not really recognizing faces as well as being very important or something to attend to. And it looks like the fusiform gyrus is part of that. Bottom graph shows that in individuals with autism, fusiform activity is positively correlated with the duration of eye fixations on the face. So this is within individuals with autism. You can have different degrees to which autism is a problem. And so for those individuals who spend less time focused on focused on the face, they have a lower signal change. So less time spent looking at the face, then less change in the brain in this area of the brain that appears to be very important for seeing faces. And the more time they spend looking at the face, and remember, this is still generally going to be less than neurotypical individuals, but the more time that an autistic individual spends looking at a face, the greater the change in the brain. Another part of autism spectrum disorder is that they have a hard time reading intent of an individual by looking at the features of the face. So children with autism spectrum disorder, they can, when they're just shown like a cartoon face, they can look at this face and say which direction that the individual is looking, up, down, left, and right. So they can read that part and just get a sense of direction, but they fail to infer meaning from gaze cues. So in this case, with the 4 sweets task, you have these different candy bars. Edvard Munch, that's kind of funny. That's the screen. This Hershey bar, but not, right? Because copyright issues, pretty fun. So they can't read intent. So when they're asked the question, which candy bar does the character want? Most of us would look at this face The eyes are gazing on peanut joy here. So this individual probably wants peanut joy. Individuals with autism spectrum disorder, they can't read those kinds of basic cues. This is obviously a basic building block for making complex inferences about the mental state of others. And autism spectrum disorder is characterized by having a deficit in this ability. So here's a table taken from this paper that looks at this in particular. So in experiment 2, normal individuals, they are 80% of them were able to determine the desire, the goal, the reference, and just as some sort of control, like determining the size of something, right? But desire, goal, and reference, these are all going to be things that are going to be inferring something about the emotional state of the character that they're looking at. They also looked at individuals, children with mental handicaps. So these were like intellectually disabled individuals, but not autism. And these individuals, despite being mentally disabled, having intellectual disability, they can still read the intentions of the characters. So they did just fine in this task. You can see that they're no different from the normal category. 80% normal neurotypical individuals can determine desire, and intellectual disability, same thing. But for those individuals with autism, it was only 40% of the children could determine desire, 20% could read goal, 5% looking at reference, and then for this category of like size, oh well, like can they still read an image and read something about it? They were fine at doing this task. In fact, 95% of them were able to say, oh well, that one is bigger than this one. So you can see that the deficits for autism really are about emotional goal reading in other individuals. And so this is really related to that communication deficit. So across developmental stages, there's a general pattern of brain enlargement with individuals with autism spectrum disorder. So they generally will have bigger brains than neurotypical individuals. And so in this particular figure, we're looking at whole brain volume, and we're looking at over the course of age. So initially, you can see that the blue line is bigger than the typically developing controls, or TDC, in this particular paper. And you can see that the blue line is higher. So children with autism are born with bigger brains. But then over time, as these individuals get older and they become adults, individuals with autism tend to have smaller brains. So their overall brain appears to decline in size at older ages. This indicates degeneration. So in particular for severe cases of autism, it can tend to get worse as individuals age. Individuals with autism spectrum disorder, the resting state studies have identified that they have reduced connectivity in the default mode network, which we talked about in the attention and executive function lecture. So this is the important network that seems to be related to exploratory behavior. This is a network that is critical for reading situations and having that internal dialogue about what is actually happening in front of us, right? And that when we are focused on something, we don't necessarily need the default mode network. If we're just using some sort of procedure and we're exploiting whatever is happening in front of us, that's when the default mode network tends to go down. So attentional and memory related tasks, we don't necessarily need it, but when we need to think about something, we need it. And so for autism spectrum disorder, they have reduced connectivity within the network. And so, this network we also know contains brain regions that are really important for social processing, such as reading faces. So for treatment, this is an ongoing issue. So individuals with autism, they tend to be very hyper-focused on mechanical things like trains and machines. Many of them, for some reason, they'll just be obsessed with trains, and trains in particular. So rehabilitation efforts, they've used this idea of morphing facial expressions It's maybe inspired by Thomas the Tank Engine or something like that. But the idea is to morph facial expressions onto mechanical animated characters. This has shown, studies have shown, you can look at this study right here if you want to learn more, that it improves emotion recognition in some children with autism. So more severe cases tend to be less influenced by this kind of therapy, but the less severe forms of autism in particular, it appears that they can improve their overall emotional recognition and reading faces better by this kind of therapy. You put something that you want them to learn on something that they're particularly interested in, like a train. Now they're going to focus on it. So another neurodevelopmental disorder is attention deficit hyperactivity disorder. This is marked as an ongoing pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. We don't actually know what the underlying causes of ADHD are. Like many other illnesses, revisiting this over and over again, there are certainly several factors that can contribute to ADHD, such as genes. You're more likely to have ADHD if there are ADHD patients within your family. There do appear to be certain environmental issues that are associated with ADHD, such as substance abuse, cigarette smoking, alcohol use during pregnancy. This is going to increase the chances of ADHD quite a bit. There do appear to be certain environmental toxins during pregnancy that are associated with increased incidence of ADHD, such as levels of lead, especially at a young age. So this can happen post-pregnancy. So we know that lead exposure will lead to increased incidence of ADHD. Low birth weight is associated with ADHD, but that can be caused by substance abuse and environmental toxins. Brain injuries can also induce ADHD, and ADHD tends to be more common in males than it is in females. But females with ADHD, they are more likely to have problems primarily with inattention and less likely to have issues with hyperactivity. And the inattention part tends to be less focused on and less likely to be diagnosed. So unfortunately, females that suffer from ADHD, they do struggle with underdiagnosis for ADHD because it tends to present with more inattentive features and not so much hyperactivity features. And hyperactivity features tend to be positive features that you can point to and say, yep, that person has hyperactivity, whereas inattention is a little bit harder to put your finger on. And so with inattention, what I mean by that is that the person tends to wander off task. They lack persistence. They have difficulty sustaining focus. They tend to be very disorganized. And that these problems are not due to defiance or lack of comprehension. So they understand what they need to do. They're not just being defiant. They just suffer from inattention issues. Hyperactivity is another feature that falls under this broad category. This person seems to move about constantly, particularly in situations where it's not appropriate. They tend to fidget, tap, and then they tend to participate in excessive talking. And then in adults, they tend to be extremely restless, and they wear out others with their constant activity. Impulsivity is another feature that often falls within ADHD. This means that a person makes hasty decisions that occur in the moment without first thinking about them, and they may have a high potential for harm or desire for immediate rewards without the inability to delay gratification. That's basically impulsivity in a nutshell. And this can be socially intrusive, and because these individuals tend to interrupt others, they also will make important decisions without considering the long-term consequences. So individuals with ADHD can have features of any of these categories. People can be hyperactive or inattentive, or both. They may have impulsivity issues, and impulsivity can be several subtle distinctions of degrees of impulsivity, tends to go along with ADHD as well. So one thing about ADHD is that this seems to be a balance of issues, problems within certain kinds of executive functions that we know are important within the brain. And one way that this has been characterized is that we have hot executive functions and cool executive functions. And so we've already kind of talked about these, but we just haven't talked about them in this context of cool versus hot. So with cool executive functions, this refers to skills that we use when emotions aren't really a factor. So these aren't emotionally dependent functions. And so this involves the dorsolateral prefrontal cortex, the anterior cingulate cortex, the basal ganglia, thalamus, the cerebellum. So a lot of these particular behaviors and skills that are not emotional dependent, right? It's particularly in the basal ganglia and the cerebellum. They are, in ADHD individuals, they have reduced function and functional connectivity in several networks for cool executive functions. So in particular, this kind of depends on the task domain tested, including working memory, inhibition, attention, and timing. So we've talked about, how the ACC and the dorsolateral prefrontal cortex are really important for attention and focus. Basal ganglia for learning procedures and doing those procedures instinctually. Cerebellum with certain corrective behaviors. People with ADHD tend to have reduced connectivity between these brain areas. So then there's also the hot executive functions. This refers to the self-management skills that we use in situations where emotions run high. There is emerging evidence for abnormal function and interregional functional connectivity in hot executive functional networks. This is most prominently in the ventral striatum. This is where the ventral tegmental area is located, and the nucleus accumbens. But this is also true. And influenced by the ventral tegmental area, the nucleus accumbens is the ventral striatum, but also in the lateral and medial orbital frontal cortex and the ventral medial prefrontal cortex, the insula, the amygdala, very important for emotional regulation, and certain temporal regions. All of these networks that we have talked about being important for emotional processing, there appears to be abnormal function and abnormal interregional functional connectivity, not necessarily diminished, but maybe even higher functioning activity within these areas, which would indicate that emotional processing tends to be high in ADHD individuals, whereas the cooler executive functions such as attention, working memory, inhibition, timing, these are all diminished in ADHD individuals, and it all makes sense. So this is an excellent review by a researcher who has studied this quite a bit. I encourage you to look at this review. Go ahead and look it up. It's got a lot of great information if you want to read more about this. The other thing about ADHD within the brain is that there's evidence for abnormally reduced deactivation in the anterior and posterior regions of the default mode network. Again, particularly during cognitive tasks. So ADHD individuals, so we talked about the default mode network, that it generally will decrease its activity when one needs to focus on doing some sort of attentive or memory-based task. So when they need focus, the default mode network is supposed to decrease its activity. And this is showing like 2-second long activity, 5-second long activity, 8-second long activity, with decreasing amounts of activity within the default mode network, within controls. This is what you normally would see when an individual needs to do some sort of focused task. The default mode network decreases its activity, right? That's how we discovered it, that here are these areas that actually decrease activity. But when someone has ADHD, what actually is happening when attention is needed, the default mode network is actually increasing its activity. And so this appears to be that the internal dialogue parts of the brain actually do not quiet, and so then attention is diminished, And this is probably one reason why ADHD individuals tend to struggle with cool cognitive tasks. They can't do the attention, inhibition, and focus and timing because the default mode network doesn't decrease like it's supposed to. In fact, it tends to increase. So, very interesting study. Encourage you to look more at. This is by that same individual who wrote the review in the previous slide. She does some really great work. If you're interested more in this topic, I highly encourage you to look up these two papers and read more about this individual here, Rubia. She's a professor, I think, in the United Kingdom. All right. So as far as treatment goes, ADHD children tend to have slower growth rates of the overall cortex, and that the prefrontal cortex appears to be particularly slow to grow in ADHD children. So here is the proportion of cortical points reaching peak thickness with age. And typically developing individuals, so just, like looking at a percent of their reaching their peak thickness, by 15 years of age, nearly all the areas are at their peak thickness. When you look at ages, say 6 to 8 to 10, most of these regions in most individuals are getting very close to being peak in their thickness. But you can see for ADHD individuals, they are very slow in reaching their peak thickness for most of the cortex. And so particularly in this range between 5 and 10 is when the deficits are greatest. This is also when we typically see, and particularly amongst boys, the most likely to be diagnosed with ADHD during these phases and these ages, and also tends to be most disruptive within schools. So this makes a lot of sense that there appear to be these neural correlates that the brain just isn't developing as quickly in ADHD individuals, particularly within the cortex. So for attention deficit hyperactivity disorder treatment, medications can work very well for ADHD. It doesn't work for everyone, but it works for many of them. One major category of effective medications, this is referred to as the stimulants. Again, this doesn't work for everyone, but these medications, they increase the duration and or release of monoamines like norepinephrine and dopamine at the synapse. So Ritalin, also known as methylphenidate, it acts as a dopamine and norepinephrine reuptake inhibitor. So methylphenidate, that's here, this is Ritalin. When you take Ritalin, it gets into the synapses and then it acts on dopaminergic neurons, as well as neurons that release norepinephrine. Here they're showing norepinephrine as it'll affect the transporters for dopamine and norepinephrine. And so these transporters normally would take up the norepinephrine and dopamine and bring them back into the synapse. Ritalin in particular appears to block these transporters so that it lasts more at the synapse. This mechanism isn't so different from other stimulants that act on these circuits, such as amphetamines and cocaine. It tends to, obviously it doesn't act exactly the same, and it has some similar effects that cocaine and amphetamines do, some greater focus on attention, but it doesn't exactly work the same, especially when taken at the appropriate doses. So as far as the prognosis for ADHD, this can really differ depending upon a number of factors. So ADHD is child onset disorder, neurodevelopmental disorder. Talked about the delayed prefrontal cortical development. So cortical thickness trajectories, they tend to correlate with symptom severity. So those individuals with particularly thin cortices have greater symptoms. But stimulants, they can act to normalize and even be, they can even improve cortical thickness in individuals, especially when treated early on. Obviously, because that's when cortical thickness is greatest. So stimulants can actually even help with some of those anatomical deficits. Now, as far as prognosis goes, some children end up with persistent ADHD. Cortical thinning tends to be fixed. This is particularly true in the cingulate gyrus, so part of the default mode network. Medial prefrontal cortices, dorsolateral cortices. The cerebellar and hippocampal development trajectories are all linked with symptom severity. So in particularly severe cases of ADHD, they tend to have smaller cerebella, as well as the hippocampus tends to be smaller as well, which would be correlated with memory deficits. But for many individuals, if they get treatment, behavioral treatment as well as medication treatment, they can have normalized cortical thinning, so they end up with brains that look no different from neurotypical individuals. And then they'll have an increased integrity of white matter tracts compared to persisting cases. So when you compare those individuals who have improved their overall behavioral output compared to persistent ADHD, you can see a difference. So the next thing we're going to talk about is personality disorders. Personality disorders involve long-term patterns of thoughts and behavior that are unhealthy and inflexible. So this is related to the core aspects of personality. So personality is one of those things that make up what an individual's constitution is. Personality development is influenced by our overall genetic makeup as well as our environmental impacts. This is true for all aspects of personality. So all of us are born with certain aspects of our personality fixed, but it's also shaped by the environment. But for those individuals with personality disorders, as they get older, they have unhealthy and inflexible aspects to their personality. It can cause serious problems with relationships and work, and people with personality disorders have trouble dealing with everyday stresses and problems. In the DSM-5, there are 10 types of personality disorders broken into 3 clusters, cluster A, B, and C, and they're all based on similar characteristics, but there is also overlap. So cluster A, we've already really kind of talked about. So cluster A is characterized as being odd or eccentric. So schizoid personality disorder and schizotypical personality disorder and paranoid personality disorder. We've kind of already talked about those features when we talked about schizophrenia. And so schizophrenia, this is where there's this overlap within the DSM, where certain personality disorders can also overlap with other aspects of diagnoses within the DSM. Now cluster B, this is what we're going to focus on the most for the rest of today's lecture. This is characterized as being dramatic, emotional, or erratic. It includes so the 4 main types of cluster B personality disorders is antisocial, which we'll talk about. This involves social irresponsibility, borderline personality disorder, intolerance of being alone, and emotional dysregulation. We're going to talk about that in great detail. Histrionic is attention-seeking disorder, and then narcissistic personality disorder is it's related to a very fragile self-esteem and overt grandiosity, and these individuals tend to be highly dysregulated. Yep, and you might know a fair number of narcissistic people that you have seen in your life, or say in politics, for instance, or in media as well. People who are particularly overly grandiose due to having a very low self-esteem but are very driven, they can actually be very successful, at least superficially, but it's because they're narcissists. So that's cool. Then we have cluster C. This is characterized as being anxious or fearful. So we have odd and eccentric, emotionally erratic, and then anxious or fearful. And so these personality disorders are avoidant, dependent, and obsessive compulsive. So we're just not going to talk about these, but these are major issues for those individuals that suffer from cluster C personality disorders. So the first personality disorder we're going to focus on is borderline personality disorder, or BPD. Borderline personality disorder is a condition characterized by difficulties in regulating emotion. So this means that people who experience BPD, they feel emotions intensely and for an extended period of time, and it's harder for them to return to a stable baseline after an emotionally triggering event. This can lead to impulsivity, poor self-image, stormy relationships, intense emotional responses to stressors. They struggle with self-regulation. It can also result in dangerous behaviors such as self-harm. So that's one of the features that can be related to borderline personality disorder. It's estimated that around 1.5% of adults in the U.S. have borderline personality disorder. Nearly 75% of the people diagnosed with borderline personality disorder are women. So 3-to-1 ratio. So people with BPD, they have wide mood swings, and they can feel a great sense of instability and insecurity. Some of these major symptoms are frantic efforts to avoid real or imagined abandonment. So abandonment tends to be a big issue for people with BPD. Unstable personal relationships that alternate between idealization and devaluation. So someone will start with BPD will start off with just being sort of obsessed with a person, and then they'll flip to, basically hating that person. And this is also known as splitting. So splitting behavior, where people are all good or all bad. They have a distorted and unstable self-image, which affects mood, values, opinions, goals, and relationships. They have impulsive behaviors that tends to be associated with this, such as that can lead to dangerous outcomes such as excessive spending, unsafe sex, substance abuse, or reckless driving. Self-harm is not a requirement, but it's one of the major indications, such as suicidal threats, or cutting is also common. Periods of intense depressed mood, irritability, and anxiety lasting for a few hours to a few days. Chronic feelings of boredom or emptiness. Inappropriate, intense, or uncontrollable anger, often followed by shame and guilt. And then dissociative feelings, disconnecting from your thoughts of sense or identity. So those completely dissociate. This can also be related to paranoid thoughts as well. Severe cases can even have brief psychotic episodes that will require hospitalization. So you can see basically all these behaviors are pretty specific, but they all seem to be related to emotional connection to friends and family, as well as emotional feelings and thoughts for one's self. For more on this, you can click on this link. So, like other mental illnesses, BPD appears to be influenced by genetic and environmental factors. So this is a figure taken from this paper here. Genetic factors are obviously the starting point for developing brains that influence and the neural circuits that control behavior. This will have an influence over our emotional dysregulation. This can lead to adverse childhood experiences. So genetic factors that lead to us to process emotions in a dysregulated way. This could lead to poor childhood experiences, but adverse childhood experiences themselves, such as growing up in, a very difficult, emotionally dysregulated home, that will have an impact on emotional dysregulation for the individual. So it's really these two factors working together that seems to be the core development for BPD. So people born in an adverse childhood experience, they're not necessarily going to develop BPD, but some of them will, and some of that seems to be influenced by the underlying genetic factors. And just because you're born with certain genetic factors doesn't necessarily mean that you're going to end up with emotional dysregulation that's characterized by BPD, because of you might not have the adverse childhood experiences that would be needed to lead to emotional dysregulation. So it's really a balance and a mix of these two things. Then the other thing is that dysfunctional behaviors that come about from emotional dysregulation, such as self-injurious behaviors, psychosocial conflicts and deficits, they can influence the emotional dysregulation and impulsivity and have an influence on the childhood experience that then feeds back into emotional dysregulation. So it's a really complex issue where you have lots of factors that can and do influence, leading to the outcome, which is emotional dysregulation. So what does this look like in the brain? There are a few studies on this, and I'm just going to cover some of the data on this. So borderline personality disorder tends to result from childhood trauma. This is one of the key features to it. So adverse childhood experience, childhood trauma, generally is going to be associated with that. It's often comorbid with other conditions such as ADHD and post-traumatic stress disorder. These all tend to be kind of tied up with each other. The amygdala, surprise, surprise, seems to be affected greatly by borderline personality disorder. In individuals with BPD, it tends to show greater response to all faces than it does in normal controls. So this is showing some data in this. The individuals with BPD, looking at the right amygdala or the left amygdala, you can see that both tend to respond. There tends to be this lateralization with the left being more greatly affected, which is really interesting. But you can see on both the right and the left, there appears to be higher activity within the amygdala when individuals with BPD are shown faces that have emotions. Just faces in general. So this indicates that substantial amygdala activity is elicited by the facial expressions in BPD individuals. It's likely to be a key component of their emotional vulnerability, that faces are a part of this. And BPD individuals tend to focus on facial features, not surprising, because it seems to elicit activity in the amygdala. Activity in the amygdala persists longer in borderline personality patients than it does in controls. And this is also true when you compare it to another personality disorder that's not necessarily amygdala dependent, so individuals with schizoid personality disorder. So in this data, what we're looking at is individuals shown a picture that's going to elicit activity within the amygdala. Blue is the controls, and green is schizoid patients. So schizoid patients and people with BPD, they have a greater response to the pictures of faces than individuals who are controls. So you can see that schizoid patients also increase their amygdala response. But the interesting thing is that the schizoid patients, like humans, neurotypical patients, they tend to diminish their activity, and so we're looking at 18 seconds post-picture onset, the activity decreases. And but for people with borderline personality disorder, they have persistent activity in the amygdala that goes on for longer, and it can go out to 30 seconds. So by the time even schizoid patients have decreased their activity in the amygdala, the borderline personality disorder patients are still higher than schizoid patients and healthy controls. So persistent activity in the amygdala is something that seems to characterize borderline personality disorder. So as far as treatment goes, it's like a lot of personality disorders, borderline personality disorder is really difficult to treat. One of the more effective forms of treatment for borderline personality disorder is dialectical behavioral therapy. This is a therapy developed in the 80s specifically to treat borderline personality disorder, but now it's become more and more common therapy treatment that is now being used to treat all kinds of psychological and mental illnesses. So it's very support oriented. It's focused on the individual so that they can feel better about him or herself. Cognitive based, and by that we've already talked about in the previous lecture that it tends to be based on cognitive behavioral therapy, but it's focused on identifying the thoughts and beliefs and assumptions that make life harder, just like this is focused in cognitive behavioral therapy. But DBT tends to have a greater focus on the emotional and social aspects of this component. So, because of the emotional problems with borderline personality disorder, it's focused on emotions. So that makes sense. It's collaborative as well. So it's about maintaining attention and relationships with clients and staff. It also includes components of mindfulness. So being focused to learn in the present moment, focused on regulating emotions, and trying to diffuse stressful and painful situations, so managing distress better, and then interpersonal effectiveness, trying to set boundaries and respect the boundaries of others. So the last category we're going to focus on is disruptive impulse control and conduct disorders. So this is the last category, and so this one actually tends to borrow and has a lot of focus or overlap with other mental illnesses, and you'll kind of see that through here. So disruptive impulse control and conduct disorders. This is one big category, includes a lot of different stuff. This refers to a group of disorders that includes oppositional defiant disorder, conduct disorder, intermittent explosive disorder, kleptomania, and pyromania. These disorders are, they can cause people to behave angrily or aggressively towards people and property. And they have difficulty controlling their emotions and behavior and may break rules and laws. So that's one sort of important component to this. So conduct disorder, this is a disorder of childhood. It tends to be diagnosed in childhood, and it's characterized by a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms and rules are violated. Intermittent explosive disorder, this is a behavioral disorder characterized by uncontrollable aggressive outbursts that are disproportionate to the level of provocation or psychological stress, psychosocial stress, and it results in negative interpersonal, financial, or legal consequences. Kleptomania is this is a famous kind of disorder, but it's actually, it's quite uncommon. The inability to resist the urge to steal objects not needed for personal use or for their monetary value. It's just an impulse that where you just want to steal, even though you don't even really need it. Oppositional defiant disorder, this is common amongst children. This can be very comorbid with autism and ADHD. It's characterized by a pattern of negativistic, disruptive, and hostile behaviors towards others, including, and in particular, to authority figures. Key features of this is that these children tend to be angry, irritable, argumentative, and vindictive, take revenge on things and people. Pyromania is something that falls into this category. This is the deliberate setting of fires, accompanied by tension before the act, relief after the act, and no secondary gain derived from the act. What they mean by secondary gain here is that it's someone who sets a fire to get revenge on someone, or set a fire for insurance, for instance. That's not pyromania. It's a bad thing to do, but it's more about something internal. And the last is antisocial personality disorder. This is kind of a catch-all, but this is tends to be more focused on adults, and then it also is one of the cluster B personality disorders too. So this is one of those categories that has overlap between two of the major subsections within the DSM. So APD is a pervasive pattern of disregard for and violation of the rights of others. The disorder begins in childhood and early adolescence and continues into adulthood. Antisocial personality disorder must be distinguished from general criminal behavior. So disruptive, just like all behavioral disorders and mental illness, it's about scale of symptoms. because all human behaviors fall upon a spectrum. Behavioral disorders are diagnosed by assessing a patient's history and testing them under clinical conditions in order to determine if enough of their behaviors fall outside of what is considered to be typical. And antisocial behavior is characterized by scoring very low for agreeableness and conscientiousness. So those individuals, so we can test anyone for their degree of agreeableness and conscientiousness. The majority of people will fall somewhere in the middle. Some of us will be particularly honest, humble, or compassionate, or non-aggressive. So they'll be particularly agreeable, maybe to their own deficit. But for those individuals with antisocial personality disorder, they're going to fall on the other end of the spectrum, where they tend to be very antagonistic, disrespect for law, they engage in physical violence, callousness, they're very aggressive, they're irresponsible and deceitful. So all the opposite of agreeableness. As far as conscientiousness is concerned, this is, so again, there's a spectrum to this. So people tend to be somewhere in the middle for conscientiousness. And there are times when people are impulsive or they engage in risk-taking. And there are times for many people who are very averse to these things where they're particularly cautious, responsible, industrious, hardworking, organized, and efficient. You can imagine people are really good at this. They're on one end of the spectrum, but on the other end of the spectrum, for conscientiousness, these individuals tend to be very risk-taking and impulsive. And it's these two categories which tend to be characterized by antisocial personality disorder. So, yeah, they'll have these two basic categories: antagonism and disinhibition, risk-taking behavior, impulsivity, callousness, physical violence, and disrespect for the law are all aspects that are abnormal features for antisocial personality disorder. Individuals with antisocial personality disorder, there's a lot of studies on this. This is a very highly cited study. There's been follow-up to this, so I can go on and on about this. But one of the very first studies to show a big difference in the brains of individuals with antisocial personality disorder in the structure is that the antisocial personality disorder, or APD, these individuals have significantly reduced prefrontal gray matter volume compared to controls and compared to those individuals who have substance abuse disorder. So people who are abusing substances, illegal substances, their overall brain matter volume is not different between controls and these, or at least, prefrontal gray matter volume, looking at the overall prefrontal gray matter volume. People with antisocial personality disorder have reduced prefrontal gray matter volume. That sort of makes sense given that these are the areas that are most important for impulsivity, attention, social regulation, those kinds of things. And interestingly, individuals with antisocial personality disorder, or APD, they have diminished autonomic responses. So their overall autonomic response, such as the heart rate, it tends to be lower in these individuals. And then they have reduced responsivity to that from the autonomic nervous system as well. So there appears to be other changes within the nervous system related to this disorder. All right, so the wrap up for this section for mental illness 2. What are neurodevelopmental disorders and personality disorders? What are some of the primary symptoms and deficits associated with the 4 major diseases and illnesses that we talked about? What are the underlying neural mechanisms or changes that are thought to be malfunctioning in these disorders? And are there treatments for these conditions? What are they and how do they work? So we talked about all these different things. You should be familiar with them for the exam. And that will be it.